Here's a medical bombshell that could shake up everything your doctor has been telling heart attack patients for the past 4 decades. Those beta blocker pills might not be the life-saving necessity we've all believed them to be. 2 groundbreaking studies have just dropped some serious evidence that's forcing cardiologists worldwide to question one of their most sacred treatment protocols. And here's where it gets controversial. For nearly half a century, virtually every heart attack patient has been automatically prescribed these heart-slowing medications. But new research suggests this blanket approach might be doing more harm than good for certain patients. Let's dive into what these game-changing studies actually discovered, because the implications could affect millions of people recovering from heart attacks. The first major investigation, dubbed the REBOOT study, tracked over 8,400 heart attack survivors across Spain and Italy whose hearts were still pumping relatively well, above 40% function. Here's the kicker. Researchers randomly split these patients into 2 groups. One group received the standard beta blocker treatment, while the other group went without these medications entirely. What happened next stunned the medical community. After following these patients for nearly 4 years, the results showed absolutely no meaningful difference between the 2 groups when it came to death rates, repeat heart attacks, or hospital readmissions for heart failure. The findings appeared in the prestigious New England Journal of Medicine and were presented at the major European Society of Cardiology Congress 2025 in Madrid, sending shockwaves through the cardiology world. But here's where things get even more controversial, and this is the part most people miss. When researchers took a closer look specifically at the women in this study, about 1,600 participants, they discovered something alarming. Women taking beta blockers actually faced a higher risk of death from any cause compared to women who skipped these medications altogether. Interestingly, men showed no such increased risk, creating a puzzling gender divide that has experts scratching their heads. Now, before anyone panics, the study authors urge caution in interpreting these results. The women enrolled in REBOOT were typically older, had more severe health conditions, and unfortunately received less aggressive treatment for their heart attacks compared to their male counterparts. Factors that could have influenced these troubling outcomes. As if one study wasn't enough to rock the medical boat, a second major trial called BETAMI-DANBLOCK emerged with its own surprising findings. This research followed more than 5,000 adults who had experienced heart attacks and retained good or mildly impaired heart function. The twist? This study actually found some benefits to beta blocker use. Patients taking these medications experienced fewer repeat heart attacks over the 3.5-year study period compared to those who went without. However, and this is crucial, there was still no difference in death rates, heart failure, strokes, or other major cardiac events between the groups. Dr. Greg Thanaro, a cardiovascular medicine professor at UCLA, explained the BETAMI-DANBLOCK trial was actually 2 smaller studies combined because neither could recruit enough participants on its own. Additionally, different enrollment criteria in different countries may have skewed the results, making the findings less reliable. Dr. Stephen Fau, a cardiovascular medicine professor and interventional cardiologist at Yale School of Medicine, weighed in on the quality of these studies. REBOOT was a cleaner study in terms of protocol and inclusion criteria, suggesting that its findings might carry more weight in reshaping medical practice. Now, here's what makes this entire situation so revolutionary and potentially controversial. The REBOOT study directly challenges more than 40 years of established medical practice that has essentially made beta blockers an automatic prescription for every heart attack patient leaving the hospital. Think about it. For decades, this has been considered standard, unquestionable care. But modern medicine has evolved dramatically since beta blockers first became the go-to treatment. Today's cardiologists have far more sophisticated tools and techniques for treating heart attacks and clearing blocked arteries than their predecessors did 20 or even 10 years ago. Dr. Fonowo highlighted this evolution perfectly. Beta blockers were developed at a time before routine reperfusion therapy for acute heart attacks and the evolution of more potent medications, and care has really evolved. In today's world of advanced coronary stents, better surgical techniques, and more effective medications, the landscape of heart attack treatment has been completely transformed. This raises a provocative question. If we can now restore blood flow to damaged heart muscle more effectively and have better medications to prevent future problems, do we still need to rely on a decades-old approach that might not be pulling its weight? Dr. Fow offered a balanced perspective that many cardiologists are probably grappling with right now. If beta blockers do have an effect, it is probably small given the other therapies we have. It fits the discussion for both studies that, with the way we currently practice, beta blockers potentially add very little to outcomes after a heart attack for patients with preserved heart function and no other pre-existing reason to be on a beta blocker. So where does this leave patients and their doctors? The medical establishment isn't ready to throw beta blockers out the window just yet. Dr. Fonowo's current recommendation is cautiously practical. If patients can tolerate beta blockers safely, they should continue taking them for now. However, he's calling for more research to identify exactly which patients benefit most from this type of medication. This measured approach makes sense, but it also highlights a fascinating tension in modern medicine. How do we balance decades of established practice with emerging evidence that suggests our assumptions might be wrong? And more importantly, how do we ensure that patients get the most effective treatment possible while avoiding unnecessary medications that might not be helping or could even be causing harm? The implications extend far beyond individual treatment decisions. If these findings hold up under further scrutiny, they could reshape clinical guidelines, influence insurance coverage decisions, and fundamentally alter how millions of heart attack survivors are treated worldwide. But here's the most thought-provoking aspect of this entire debate. These studies represent a perfect example of how medical facts that seem carved in stone can suddenly become questionable when viewed through the lens of modern research and improved treatments. What do you think about this potential medical revolution? Should doctors immediately start questioning the automatic prescription of beta blockers for heart attack patients with good heart function? Or is it too risky to abandon a treatment that's been standard practice for 4 decades? Are you someone who's been prescribed beta blockers after a heart attack? And if so, how does this new evidence make you feel about your treatment plan? Share your thoughts. This is exactly the kind of medical controversy that deserves robust discussion from patients, caregivers, and anyone interested in how medical practice evolves.